Information in the past few weeks. I know I have. Our speakers were phenomenal. We talked about the overview of health, which encouraged a lot of our men's ministry to get involved and stay healthy with their challenge. We've also talked about COVID 19, diabetes, and kidney problems. And tonight we're going to focus primarily on cancer. We have heard some statistics that were overwhelming. We know a large percentage of our cancer individuals who have actually gone through a challenging time during the pandemic. We've noticed those numbers have increased because of the fact that people have not gone to their physicians. They've not gone to get tested for cancer. And so here tonight, we thought it was very befitting and important to talk about a topic that is truly important to us here in the community, especially in the African American community. But before we get started with our Summer Health Series, of course, first and foremost, we want to acknowledge our pastor, Pastor Jonathan E. Logan, and our First Lady, Christine Logan. We also want to thank all of our members that are here. And of course, we must begin with prayer. So before I introduce our wonderful speaker, I ask that each and every one of you all, if you could close your eyes, if you're in house, if you're driving, just stay focused. I would like for you to open your hearts as we begin with prayer. Heavenly Father, we thank you for allowing us again to gather here together to meet the needs of our community members, Lord. We thank you for those who are our experts in these topics that we have each and every night. We thank you for the knowledge that they have delivered to us. We thank you for giving them the understanding that it is so important to educate our community outside of the clinical area. We thank you for allowing those to be able to come in-house so that they can get this knowledge firsthand, and those who are online so that they can actually get this information online as well as being recorded, so if they're unable to retrieve this information tonight, they can look back at it later or share with their loved ones. We thank you, Heavenly Father, for giving us our health, our strength, and being able to continue this program. We thank you for over 16 years of the knowledge and the understanding, and also the alignment of the scriptures that have been really put forth during this program. We thank you again for our hostess, myself, Dr. Angela Allen, and also Dr. Pullins, for being able to get wonderful speakers to be able to deliver the message as we have done in so many years. We want to continue to ask you to bless us and to give us a continuous understanding. We ask in your holy name, Heavenly Father. Amen. So again, we want to thank all of you guys who are here, those who are in-house, and also online. I want to just share with you that it is an honor and a privilege for this speaker to come up. She and I worked in the community for some years. I am part of the Coalition of Blacks Against Breast Cancer, and also by default, the Coalition of Blacks Against Cancer, and also prostate cancer, because I believe in the mission. I also believe in the fact that we need to be able to help our people, because we are very familiar with our scripture, Hosea 4:6, our people shall perish due to the lack of knowledge. So we want to again thank you, and I think tonight we're going to do a little something different. I've heard her introduce her story and share why she's doing this, and also provide information on CBBC, CBAC, and CBPC. I'll say that fast. But I said to her, Dr. Michelle Halyard, I'd love for you to share your story and introduce yourself, because it's more touching, it's more passionate, and it gives you an understanding of why she does this wonderful work. So without further ado, I'd like to introduce my friend, Dr. Michelle Halyard.
Thank you, Dr. Allen. It's a real privilege and pleasure to be here with you. I feel like Antioch is home. Pastor Logan and all of you have been so supportive of the work that we've done, and actually our first expansion site outside of our long-standing Coalition of Blacks Against Breast Cancer site in Central Phoenix. So Dr. Allen asked me to tell my story. So I'm a radiation oncologist. I'm a doctor that treats breast cancer with X-ray therapy. I focus on breast cancer. And some ask me how I came to do what I do. Well, when I was 5 years old, my mother was diagnosed with breast cancer. And at that time, it was a lot different than it is now. So she disappeared into the hospital for 2 weeks, which now they barely keep you overnight, if at all. But she disappeared for 2 weeks. And all I know is that she came back different. Well, what had happened to her is even though she had a very, very small breast cancer, she had a radical mastectomy. So in those days, for those of you like me old enough to remember, what they did was they took the breast, they took the muscles on the chest wall, they took on all of the lymph nodes under the armpit. And what that left her with is a very smart, vibrant woman who was never the same. She worried a lot. She had to wear a prosthesis in her bra because she had a sunken chest. So she was always careful about what she wore. And she developed what we call lymphedema, or some swelling in her arm, because all of the lymph nodes were removed. And her quality of life was greatly impacted by her disease. So lo and behold, and I should add to the story, thankfully she lived well for another 40 years. She never died of breast cancer. She died of Alzheimer's, actually, which is another disease that Dr. Allen is passionate about and affects our communities. But she was never the same. And so I wound up going into breast cancer. That was the last thing I thought I was going to do when I went to Howard University for medical school. I said, I'm not doing oncology, but I wound my way around. And my research interest is in quality of life in cancer patients. And I think it's a direct response to what I remember growing up as a child. So this is why I do the work. I'm really passionate. I'm passionate because for any type of cancer, like many other diseases, we as Black people die at a higher rate. And there's some things that we can do to change that. So about a decade or so ago, one of my colleagues and I were talking about how can we make an impact within the community. And he, Marion Kelly, who some of you may know is head of community outreach at Mayo Clinic in Arizona. And so we came up with the idea of asking the community, what do you need around cancer, and particularly breast cancer? And they said we need support for breast cancer survivors, because as you know, in Phoenix, we're not here in small numbers, but you would think we are, because we're all spread out. And I had so many patients tell me, I don't see anybody else that looks like me. I don't see anybody else that can provide me hope that since I'm diagnosed with breast cancer, I won't die of it. So we decided to start the Coalition of Blacks Against Breast Cancer, CBBC as we call it for short, to provide support for breast cancer survivors. And we have met for the past 12 years, the third Sunday of every month from 3 to 5 p.m. in Midtown Phoenix, providing a support group and education, which is a great group of people. But we also knew that was not enough, that we needed to do education and outreach into the community to talk about the importance of breast cancer screening, to talk about not being fearful of getting a mammogram, to talk about if you are diagnosed with breast cancer, it is not necessarily a death sentence. There are many, many women that survive breast cancer. So we talk about screening, diagnosis, treatment, and survivorship. So here we are 12 years later, and we knew, well, we're well on our way to covering the women, but we got to do something with the men. And so we decided to form another organization called the Coalition of Blacks Against Prostate Cancer, which just launched in May. And we formed an umbrella organization, which you see here, the Coalition of Blacks Against Cancer. So you see my title, Breast Cancer and Prostate Cancer Awareness, what every woman and man needs to know. So I did that purposely because a lot of times it's the women that are going to the doctors. A lot of times it's dragging the men to the doctors. You know, I have to tell my husband, okay, it's time to see your doctor. It's time to get your prostate exam. And he tries to ignore me like he doesn't hear me. But we are often the folks that are bringing our loved ones to the doctor. But men need to know this data as well as women about breast and prostate cancer. So next slide. So there are a lot of breast cancer in this country. Almost 300,000 people are diagnosed each year. And it's not only women. So men can get breast cancer too. And I think a lot of times people forget about the fact that a man can get a breast cancer. So it's important, as it is for women to know their body, and particularly their breasts, for men to know theirs as well. Only about 1 or 2% of breast cancers are men, but it can occur. And in Arizona, there are about 6,000 cases of breast cancer a year. So The good news is that we as people of color, as black people, do not develop breast cancer necessarily at a higher rate than whites, but but we tend to present at more advanced stages of disease, and there's many factors for that. Some is cancer biology, some is perhaps getting to the doctor as quickly or screening. But the good news is 80% of women with breast cancer are alive at 5 years. 90% of localized breast cancer, where it hasn't metastasized or spread distantly, are cured. The death rates are decreasing with the research and new treatments that we're coming up with. And women can survive and thrive. And I know we'll hear one of your members here talk about her experience with breast cancer once I'm done, and she's a living testimony to the fact that she's thriving. So again, the survival in breast cancer in black women can be lower. We have tendencies to develop a more aggressive type of breast cancer called triple negative breast cancer, where it's not responsive to hormone blocking therapies. And we're not quite sure why there's a higher risk of triple negative, but it tends to be more prevalent in women of color, and the survival tends to be lower. We tend to present with what's called higher grade disease or more biologically aggressive disease, as I talked about, later stage of diagnosis. And sometimes we, as a population, have less access to higher quality, timely treatment, and also sometimes underlying illnesses, diabetes, hypertension, other things that can impact our overall life as well. So what is breast cancer? What is cancer at all? So cancer is a condition where you have normal cells in the body, such as on my left, and they normally grow and divide in an orderly fashion. But when someone develops cancer, cells for some reason are triggered to keep dividing and growing, and eventually they push through the borders of the tissue where they start, and they invade into spaces where they can get into surrounding tissue, lymphatics, or blood vessels. So no matter what kind of cancer you have, the underlying biology is that there's cells that keep dividing. It's important to know that breast cancer is not one disease. There are different types of breast cancer, even though they may be called the same thing, like a common one is invasive ductal, where it starts in the ducts and moves out, or invasive lobular, where it starts in the milk ducts and moves out. But there's many different subtypes. There are those that are responsive to hormone, estrogen, and progesterone blockers. There's some that are not, such as triple negative. There's some that are what we call HER2, which have a different type of protein on the cells and are treated differently. So this is why, for anybody that's diagnosed with breast cancer, they can't necessarily listen to all their friends and family talking about how they were treated, how somebody that they know was treated, etc., because everybody's case is really individualized. And now we're finding a lot more that we in our field are doing genetic testing on the tumor cells to tell what type of therapy it may be responsive to. We're finding even more about how to treat people on a personalized basis. So this is an example of what a breast cancer is. So that's a side view of the breast. You see the muscle on the left side, muscle and bone labeled F and G. You see the little ducts that go toward the nipple. Those are the milk ducts, and the little areas that are demarcated by the B is the milk sacs or lobules, and E is the fatty part of the breast. And down there is, if you cut the breast duct like a hot dog, and you look on the inside, and they're normal cells that line the rim of the duct, and when they become cancerous, they grow and grow and grow, and then push out into the surrounding tissue, and can actually then invade into blood vessels or lymphatics, particularly if they're not caught early. So what causes breast cancer? So I cannot tell you the many times women say, I don't get a mammogram, I don't worry about it, I don't have a family history of breast cancer. Well, Only 5 to 10% of people diagnosed with breast cancer, from what we know today, have a genetic component, meaning that it's passed down through their genes or through their family. That means that the vast majority of breast cancers, we don't know what causes it, it's just sporadic. So just because you don't have your breast cancer does not, or family history of breast cancer, does not necessarily mean that you're not going to get it. In many cases, it doesn't mean that. But it is important to know your family history, because if it does wind up being genetic, you typically see multiple people having breast cancer or ovarian cancer, even prostate cancer and colon cancer. You typically see younger onset of breast cancer. Typically, breast cancers occur in people in their 60s and 70s. You tend to see younger people. Both sides are bilateral breast cancer. And as a matter of fact, we in our particular practice, for anybody that's diagnosed with breast cancer at age 50 or younger, we do a genetic test to see if it's genetic. Know your family history. So here are a whole long list of risk factors, some of which we've talked about, but some of the things that on the right-hand side of the slide are, I think, particularly important to understand how you can impact your risk of breast cancer. We know that drinking alcohol increases patients' risks of breast cancer, as well as other cancers like esophagus cancer and others. Taking hormone replacement therapy has been shown to increase risk of breast cancer in certain studies. Being overweight or obese, and particularly having no physical activity and not breastfeeding, has been shown to increase the risk. Okay, next. So early detection is the key. Early detection, and importantly, if you are diagnosed, being treated. God gave us the tools to treat. And people often are fearful of treatment. And I'm not saying cancer treatment is easy by any token, but you need to be treated if you have a cancer. And the death rate from breast cancer has declined 40% over the past decades because we're developing more effective therapies all the time. So know what's normal. It's important to examine your breasts to know what they look and feel like and report any changes to your healthcare provider. The changes that you're looking for are any change. You need to know, first of all, what's a baseline for you, what's normal for you. And I know older women tend to have, in general, fattier breasts, which make it easier to examine. Sometimes women are young and they've got cysts and things like that, but you've got to know kind of what your normal baseline is. And then you're looking for changes. Not every breast cancer presents with a hard lump. That's a fallacy. Not everyone does. Sometimes it's a thickening. Sometimes it can be a lump or a hard knot, but sometimes it can feel other ways. You want to look to see if there's any swelling, darkening, or redness of the breast, either in a particular location or the entire breast. Obviously, when you have swelling and darkening or redness, we want to rule out infection, but a lot of times that's the way a breast cancer can present, even if you can't feel anything abnormal in the breast. Is there a change or shape in the size of the breast? I am not talking about when we all gain our COVID pounds and both breasts get bigger, myself included. I am talking about, is one breast bigger than the other? Do you have any dimpling or puckering of the skin or pulling in of the nipple? Itchy, scaly rash on the breast, nipple discharge, or pain in one spot that doesn't go away. In general, breast cancer is not painful. It can be, though. Every breast lump is not cancer. 70% of things that we feel in our breasts are not cancer. So don't get paralyzed by finding that lump and saying, I'm just going to pretend it's not there. You need to check on it, because a lot of times women put themselves through agony thinking that they have something and they really don't. But don't get a false sense of security. See your doctor or your mid-level provider. So getting screened. I think many people had an opportunity, thank you. Many people had an opportunity to stay in their houses all during COVID, right? I know I did, except for going out to work. So many of us may have missed our mammograms. And so I would say that if you're age eligible to get a mammogram, please do it if you haven't. talk to your doctor about which screening tests are right for you. Mammogram is the gold standard. There is no blood test like with prostate cancer to pick up a cancer. So the recommendations is starting at age 40. If you're at average risk, start mammograms. There are different recommendations about how frequently. Some say between 40 and 45. It's up to you if you want to screen or not. We at Mayo and American Cancer Society recommend starting at age 40. If you have a first-degree relative like a mother, like I did, you start screening about 10 years earlier than their diagnosis. So my mom was 43. I started my first mammogram at 33 and then started screening annually at age 40. So the other thing is from age about 50 to 74, well, 45 to 55 screening every year, and beyond that every year to every 2 years. When to stop screening should be discussed with your physician or your mid-level. If you've got a lot of other health problems and a short life expectancy, screening mammograms may not do any good. But if you are doing well, healthy, long life in your family, some people choose to continue to screen, because older women can develop breast cancer. So mammography, again, is the breast screening tool. This is what a mammogram looks like. I think hopefully everybody in here who's age eligible has had one. You stand in front of the machine. There's 2 x-ray plates that squish your breast. It is not the most comfortable thing, but it's about 30 seconds of discomfort. The entire time you're thinking, I know a man designed this, because if a woman designed it, it would be easier, right? And so unfortunately, we don't have anything better, but it's really important to get it done. And some people are afraid of, they said, well, I know it hurts. Well, it's about 30 seconds, truly, of pressure. Hold your breath for 30 seconds, release it, it's done. This is an example of what the radiologists are looking at. This is an x-ray. I know it just kind of looks like black and white stuff. Thank God they're radiologists that can actually read these, but they're looking for any changes on the mammogram, including circle or densities, I should say, or calcifications. So what can you do? Maintain a healthy weight, add exercise into your routine, limit alcohol intake, limit postmenopausal hormone use, and breastfeed if you can. Know your family history, and that can help us understand if you have multiple relatives with different types of cancers. We kind of look through and see if there's a pattern. We'll sometimes send you for genetic testing that can help guide your therapy. So after surviving after a breast cancer diagnosis, seek the best care you can. Educate yourself from credible resources. There's a lot of junk out there on the internet. I would encourage you to go to reputable sources like American Cancer Society, National Cancer Institute, Mayo Clinic, MD Anderson, Memorial Sloan Kettering, big academic centers. Know your treatment options, find support, and remember, everybody's cancer journey is different. So I think I'll skip past a little bit and we can answer questions. This, takeaway is that you do have to have a biopsy to prove that you have breast cancer. Some people are scared of that. It winds up that you get an area of the breast numbed. They put a needle in the tissue, take out a little bit of tissue sample, and most women tolerate it quite fine. And there are different ways to treat breast cancer. Mastectomy is not always what you need or have to have. The survival between mastectomy and lumpectomy, where we just take the tumor out and give radiation to the breast, is equal survival, and your surgeon will talk to you about whether you're a candidate for one or both. Sometimes people need radiation or not. Sometimes people need chemo, not always. Some people need hormone blockers or other treatments, but there are different ways based on the biology. And clinical trials there, and this goes the same for prostate. The only way that we are going to make advances is to understand what new treatments provide better survival. We're all, I think, scarred as Black people by Tuskegee. We've heard that over and over and over again, but there's a vast difference between what happened to Tuskegee and withholding treatment versus clinical trials of today. Remember, there are very few trials that are written for just specific populations. Everybody in general is eligible for a clinical trial. There are many safeguards that are in place to help people on clinical trials. I've written trials myself trying to help people be treated better for cancer. So please ask if there's a clinical trial and listen to what they have to say. So this is the mission of Coalition of Blacks Against Breast Cancer. If you know any breast cancer survivors, please forward them our information. There's information on the back, and we invite you to join. So prostate cancer, can't leave the men out. So what's the prostate? So the prostate is a part of the male reproductive system. It's a small gland that sits at the base of the bladder, and the urethra, or where the urine comes out, runs through it. There are several lobes of the prostate. The back part of the prostate toward the rectum is where prostate cancer usually develops. So there are almost as many new cases of prostate cancer as there are breast cancer in this country. Black men tend to develop prostate cancer at a rate of 1 in 7 in their lifetime. And with most cancers, black men are more likely to be diagnosed with and or die from prostate cancer than white men. So 6 in 10 cases are diagnosed in men who are 65 years or older. It's rare under the age of 40, although you can see younger onset if you have a family history. In breast cancer, we can see breast cancers in women in their 30s, even in their 20s. That's young age of onset's rare for prostate, but it can happen with breast. And the average age is in the mid-60s. And important to know that many men die with but not of prostate cancer. So prostate cancer, not always, but not infrequently, prostate cancer is one of those cancers with either not just kind of observing it without treating it, or doing some treatment can allow men to live very long and die of other things. So prostate, unlike breast, where you can kind of examine your breast, you can't examine your prostate, right? So often it's not symptomatic. And so early detection is key, but what does that mean? So it actually means for most men having a rectal exam annually, which is not the favorite thing of men, I know, I understand that, but also having a PSA, which is a blood test, which tells if there's a particular protein circulating around in the blood that's a marker, that can be a marker for prostate cancer, although it can also go up if the prostate gets big from just age, which it sometimes does, not infrequently. So if someone has an elevated blood test or a PSA, the doctor has to sort out what's this from. So the risk factors: older age, black men tend to get prostate cancer more frequently and diagnosed earlier. In the United States, there are different parts of the world that tends to have a higher risk rate of prostate cancer, including the U.S. Family history, and also people who have the BRCA1 and BRCA2 gene, but BRCA1 twice, it's BRCA1 and BRCA2, which is a gene that is a marker for breast cancer, that can predispose people to prostate cancer. So what I mean by that, if somebody has a mother or a sister or someone in their family that has a BRCA gene, the men in the family may be more predisposed to prostate cancer. So it's really important to understand, again, that history, understand that if you are diagnosed and they recommend genetic testing, that you pass along the information that you can to your family members. So there's no sure way to reduce the risk. Some things that may help are optimizing weight and optimizing your physical activity and diet, which helps so much. And I know Dr. Allen has been educating everybody in the world that will listen about these healthy lifestyles, and so that's important for this as well. There are certain drugs that have impact on the male hormones that may reduce that risk. Some studies suggest aspirin may, others not. And there are other drugs that are now being studied. So we talked about, for screening, a PSA is that blood test. There's a certain level beyond which you start to wonder, what's going on. Do we need to do more testing? Depending on how high it is will kind of dictate what tests they do. Sometimes they watch the PSA and see if it goes up, because again, sometimes the PSA can go up just from benign enlargement. And there's a biopsy that has to be done if they feel a mass or if they see that the prostate is really enlarged, and they put a needle through the rectum into the prostate. There are different treatment options. One includes doing nothing. Not infrequently, men may be older, have a lower grade or less aggressive prostate cancer, and the doctor may choose to observe it. If you're given that recommendation, if you question that recommendation, get a second opinion. We always recommend people going at second opinions. You'll learn about something, you learn a little bit more every time, even if they give you the exact same recommendation. Sometimes we treat with radiation therapy. Sometimes we remove the prostate surgically. Sometimes we have to do surgery and then radiation following. And also sometimes people are put on blockers that block the effect of male hormone testosterone on the prostate, so it doesn't kind of feed the prostate. So we've started the Coalition of Blacks Against Prostate Cancer. It kicked off in May. Just like CBBC or the breast cancer group, we're now holding monthly support meetings. The prostate cancer group is in person. The Coalition of Blacks Against Breast Cancer is hybrid. So we're doing both in person, and people are now being able to watch on Zoom. It's the only good thing I can think of that came out of the pandemic, is the fact that it forced us to go virtual for 2 years, and now we're just kind of easing our way back in. We hope to reconvene CBBC at Antioch soon. We thought that we needed to kind of take baby steps into getting back into the environment of delivering it in person, but we hope to be back here soon, and hopefully one day we'll also have a prostate cancer group out here as well. We recognize that men don't always necessarily share what's going on in their minds, but we thought it was important to bring them together to share their experiences of prostate cancer, bring their spouses, just like spouses are encouraged to come with women to CBBC, and we want to educate and outreach into the community. So with that, I will end and turn it back over to Dr. Allen.
Thank you.
Okay,
I appreciate it. So what I'd like to do is, if we can go to the Coalition of Blacks Against Breast Cancer mission slide. If we can move to that slide, I think that's so important. I don't know if we can kind of get to that. It's a couple of slides like in the middle, if you will. So, yeah, if it could be, well, don't worry, we'll get it there. But I wanted to talk a little bit about the Coalition of Blacks Against Breast Cancer, which is very much aligned with prostate cancer, as mentioned. And then also we have coalitions Blacks Against Cancer. So we look at various cancers as well. Can you share a little bit about that? And then I'd like to then talk a little bit more about the support group, because I think that's so important.
So the Coalition of Blacks Against Breast Cancer was our first group. Again, we've been going for 12 years. We decided we needed to do something for prostate cancer, so that spun off Coalition of Blacks Against Prostate Cancer, but we needed an umbrella organization, so we created the Coalition of Blacks Against Cancer. So our goal is really to try to educate the community more broadly about various cancers, with a focus on breast and prostate. But we've done education on colorectal cancer recently, and we plan to continue this education. And our mission statement is to really give quality, reliable information to the community in a supportive environment, and it's geared around survivors. So survivors, whether they're breast or prostate, I mean anybody from diagnosis forward. It doesn't mean that you're reached 5 years and you haven't had a recurrence. It's anybody that has ever had cancer or has cancer. And importantly, we're educating about the community, about breast and now prostate cancer screening, diagnosis, treatment, and survivorship. And you see our tagline, share your story. Just as you're about to hear a story from a wonderful survivor, we think it's vitally important that we show that people can survive cancer. People can survive breast cancer, prostate cancer. And so we have our survivors, as part of our outreach, talk about their journey and really show that they're living, thriving, surviving, so that it encourages others.
Thank you so much. And so that's what I wanted to make sure many of us have seen the mission. It's like I said, I belong to many organizations, but I choose those that I want to be involved in because I believe in their mission. And I am not a survivor, but I'm considered a supporter because as Dr. Halyard states, I try to get as much information about health out to not only in the worship environment, not only in the clinical setting, but I think more importantly in the community so that we can prevent those coming into the clinical setting. I also wanted to elaborate that this organization is phenomenal. I've participated in some of the events virtually and in person. And just to give you an idea how it's set up, it's typically on the third Sunday of each month, and it is actually from 3 to 5. And for those of you all who may be concerned, how does this work? She just said virtually, she said in person. I'm a little apprehensive of sharing my story, that between 3 and 4, it is only closed to the survivors. And when I say I have to have tissue when I'm listening to their stories, when I'm listening to not just the survivorship, but the support that they give each and every one of them themselves. And by the way, I needed to throw this out there, Dr. Halyard. They're in Chicago, Washington, D.C. I mean, these people are from all over the area, so they're not just in Arizona, because this program has actually touched the heart and lives of so many individuals. And so they're calling in. I remember listening to one individual, she's in Chicago, and she's just like, without this, I wish we had something here, but without this, I don't think I would have made it. I myself was invited to an event this last weekend. Dr. Halyard asked for me to speak at a young lady's birthday party, and from my understanding, she lived here, and then she moved away. Now she's back, and she wanted to, at her birthday party, phenomenal birthday party, she said, I need someone from CBBC to come and speak. And it was so amazing because what she did at the very end was she said, I don't want birthday money. I want all donations to go to CBBC because of what they've done for me and my family. And I thought that was just so heart-touching, the fact to know that this organization not only just touched the individual, but it touches the lives and the families of those who have been impacted by the disease. So Dr. Halyard mentioned something earlier, and I want to make sure that we actually acknowledge that person. So without further ado, I'd like to call up one of our members here at Antioch Church of God in Christ, and that is our very own sister, excuse me, I want to call her Sister Christine Billingsley, so that she can share her story. Okay, so.
God bless you, everyone. Good evening. Good evening. I'm thankful and grateful that you awarded me this opportunity to share my story. As everyone knows, I'm on the quiet side, but I thought it very important to share my story because, again, to inspire, to encourage, but again, to where we can become more knowledgeable. I'll start out by, as far as just saying that with me, my story began last year around September 2021. I usually get my mammograms. I'm faithful about that, but during 2020, the pandemic, and what happened was I went to get it, but Luke Air Force Base, the mammogram machine was down, and they were doing off-base referrals, and then they would say, okay, no, come on back, the machine is up. And long story short, I did not get my mammogram for 2020, but 2020, 2021, I went back on schedule as far as what I went and scheduled to get my mammogram early in September. With the mammogram, I was called back to the radiology department where they informed me that, okay, we're seeing something suspicious on your mammogram. We want you to come back. I did go back, and from there, the radiologist was able to look at the screen and tell me, from, the previous mammograms, okay, we're seeing some small clusters, calcification clusters. They're forming, and that's suspicious. So we want to go on and get you off base and get diagnosed and see what's going on. So I was scheduled for stereo. Well, let me back up because again, I want to just, when you hear that, they weren't saying cancer, but they called it DCIS. So, in my mind, that kind of calmed me down. Okay, ductal carcinoma in situ. So meaning it hadn't broken through the cells, but it was early detection. So that's why I implore you ladies, I implore you men, get those mammograms, schedule those mammograms and go to them. I did share what I was going through with at our watch night service. Again, and all I could say was, I trust God. I trust God. I remember going to my first lady and pastor, it's going to be all right. Look, God's got you. God's got you. Go through the process. And, I just thank God for the support system as far as just people praying for you, from the intercessory prayer group to, the family and friends, people that heard, whatever you need, coming, wanting to bring food over, whatever was the case, but just a support, letting you know you're not by yourself through this. So I did go through a stereotactic biopsy, and that is where you're laid on a table and your breast is put through the table where they can do the biopsy. Mine was because of the area that it was at. They had to remove the pillow, so it was very uncomfortable, but it's one of those things that you need to go through to find out what is going on with your body. So when they did come back, they again said, they wanted to try to do the surgery and to remove what was in there before, it spread. I did go through the Ironwood Cancer Treatment Center in Glendale. That was the center that I was referred to. It was just kind of like just walking through it, but okay, go through the process. Just kept hearing Pastor in the background, go through the process. With the process, it included where in January I had surgery. They removed the cancer that was still contained. They did like a margin, 2-inch margins on each side to make sure that they got all the cancer before it spread. And when the biopsy came back, they said that it was at the top of it, the margins, again looked like it was suspicious or that there was cancer, but they at that time referred to that they wanted me to go through radiation treatment. So I did radiation treatment for 5 weeks. You go in, you get in your gown, and prior to that they fit you as far as, so when you are laying on the table, you're not moving, and it's very targeted. So they don't want to, they're going to sometimes hit some of the normal cells, but for the most part, it's going in for the cancer. So I was. Just as far as with the radiation treatment, 5 weeks, like 10-minute dosage, I didn't feel the pain or the discomfort until much later. But again, different ones did suggest as far as some of the things to help relieve the pain and the discomfort, as far as the bras, the support bras that you wear, the creams that you could use, the Aquaphor lotion, and one member of our church, Jackie Ford, had heard about my diagnosis, and she said from all the way from Chicago, some shea butter and 100%, I believe it's 100% shea butter and hyssop oil. That was a mixture, and it worked. It took that sting out and different things. And, I just thank God that through the whole process, God sees you through it. And I look back and wonder now, because again, my last appointment that I had with my doctor, he did say that the cancer was gone, but again, I need to go back as far as September, October timeframe to get one more diagnostic mammogram to make sure that the cancer is gone. And with that, with the journey that I've gone through, I do ask God just to help me to be able to share with different ones and to encourage different ones as far as with getting those mammograms and just being there for one another.
Yeah, I appreciate you, Sister Billingsley. I can share with you, I think Sister Billingsley, first and foremost, God. She's a woman of God, and I love the fact that you continue to say that. Secondly, and I have to acknowledge in order, your husband was such a phenomenal support, I'm sure. And then also First Lady Pastor in the church. And I think what you're hearing for those who are in virtual land, because I don't have to say this in our church, that we have a phenomenal foundation of spirituality, and we acknowledge that. So even though we talk about prevention, we know that we can't prevent every disease that come before us, especially in our church. But I can tell you here, it's been seamless, because I know when I had seen her, when I missed her, because she's part of my working with the department, it was acknowledged. But then when she came, it was almost as if nothing had happened. But we know that women and men go through emotional concerns. So I wanted to ask both of you, as a clinician and also someone who has gone through that, what are some of the emotional and mental concerns that have been expressed? Let's start with you, Sister Billingsley. What are some of the concerns that you've shared? Because it is a journey, and it isn't all that great. So there were some things I know you may have gone through.
Well, one thing is when you always hear that word cancer, immediately you think death. But you have to, draw within that faith that you have in God, that I will live and not die. And I'm here for a purpose. And for me, I even went to journaling as far as just how I felt every day. The days were, okay, I'm doing okay, but some days like, a friend would call, someone would just out of the, hey, Sister Taylor, look, here's some bottom cupcakes, something just to cheer you up. The pastor and the first lady sending a plant, those little things that just encourage you that you're not by yourself, those little things that just encourage you that you're not by yourself in this, but it's the faith in God that's going to get you through.
So nobody but patients who have been recently diagnosed. So often when I see patients who have been recently diagnosed, they're shot of fear, there's disbelief, sometimes there's anger, a lot of fear, as you said. So for anybody that hears that word, the first thing they're thinking of is, am I going to die? And sometimes if people don't process it right away, I kind of worry about them, because I think it's going to come out later on. So kind of don't necessarily push it all down, but everybody's way of coping is different. I think that's what's so great about CBBC. I think I've learned how to be a much better doctor in these last 12 years than the past 20 prior to that, because you really get to see the impact of cancer on people and families, because it does impact families as well. And Dr. Allen talked about, there's tissues at CBBC, but there's a lot of laughter, right? So I think the great part about the group is there are women there that are newly diagnosed, that are going through treatment, all the way out to people who are 20 plus year survivors. And everybody's providing support to one another. It's a great place to come and get questions answered. Have you gone through chemo? How did you handle this? What's radiation like? Because part of what we do is we do a lot of education, and putting a plug in for the organization, you'll see on the pamphlet that we have in the back on the table. We have, if you go on there, we have all of our education resources. We have all of the education sessions that we have recorded. They're there for you to review. So please share it with other people.
And you may have heard Dr. Halyard say in the last 12 years. So CBBC was established around 2010 or so. And so I remember going to their celebration. I think it was 2020 or 19 that we actually, and it was a lot of fun. It was a lot of celebrating the lives that were impacted by this organization. So thank you again for sharing that. I wanted to kind of put a plug in with COVID, a couple of things, and I as a community advisory board member of Mayo, I remember attending one of the presentations, and they did a presentation, Maricopa County and Mayo did a presentation on the community health needs assessment. And one of the things that I remember reading on that document was that due to the pandemic, there has been an increased number of individuals, particularly those people of color, who have had decreased or delayed care treatment during for cancer. Could you elaborate on that, and could you tell us what we should do, or what are some of the things we should say to encourage people to actually get assessed?
Well, we just heard you say that you skipped your mammogram in 2020, right? And so I think a lot of people did, right? You know, I didn't go to all of my doctor's appointments except the ones that I really had to. And I'm an oncologist, right? So it's like, okay, I usually go every 12 months. Oh, goodness, it's 18 months, right? So if you haven't done what you need to do, if you haven't seen your doctor, if you haven't had your mammogram, if you haven't had your prostate check, go, right? Make up for that lost time. And also, I think a lot of us perhaps did not take as good a care of ourselves during the pandemic as we could have. I did a whole lot of COVID crunching, as I call it. And so, you know, I gained weight, a lot of people gained weight, a lot of people didn't get their exercise, but it's never too late to try to do a little bit better, right? And so we can't all be perfect. I'm never giving up my popcorn, but you know I need to get back out walking, I need to do those things. So really making your health a priority. And I think all of us work so hard and have so many stressors, a lot of times we put ourselves last, right? We take care of everybody else, but we have to take care of ourselves.
Yes, and I do want to also encourage those who are looking in-house as well as online, when you go back to this, because this is recorded, there was a particular slide that Dr. Hellyer pointed out on risk factors, the areas that we need to address. Of course, a diet, exercise. Many people say, well, my family member did not have breast cancer, so I may not have it. But if you remember the number, she said 5 to 10% family history. And one thing about it, Dr. Hellyer, I'll throw this in, our last presentation during the Summer Health Series, we're going to be talking about genealogy. So we'll be focusing on our family history. Thank you for this slide. But yeah, we menopausal, hormonal, alcohol, all of these things. And for those of you all who are in-house or those who are looking online, I would take a picture of this so that you can kind of get an idea of some of our high risk factors that impact those who have had breast cancer. Once again, we're going to start with questions in the audience and those that may be on Facebook. But I just want to encourage you all, again, I look at this picture, I paint this picture in my head, and I think it's so important that we need to recognize this, because if we know better, we'll do better. If we can prevent certain things from happening, we will. And when it impacts us in our close spiritual family or in our family, then it's a concern. Let's not make it a concern. Let's try to prevent it from being a concern. In 2009, I think I've shared this story as well, October 2009, I actually had a little scare as well, had a biopsy, and thank God it was negative, but it allowed me to have a better understanding of why I'm part of this group. I have family members and friends that call me all the time, and I always refer them to CBBC because I think they have more knowledge and information on such a detailed diagnosis such as this. So do we have any questions in the audience, or do we have any online? Yeah, we have a question in the audience. So we can give a person a mic here. Thank you. Yep. Yes. We'll get it. So we're going to get a mic. That's okay. So yeah, we have a question in the audience, and if there are any other questions, please feel free to ask. While we're getting prepared for questions, as always, remind those who are in-house, we do have our raffle. So we want to graciously thank CBBC. They actually have the raffled gift for today. So I'm excited to see what that person wins once they win it. So just as a reminder, everyone should have their tickets. We have a question, yes.
My question is, I had a lumpectomy one time, and once they biopsied it after they took it out, it had HPV in it. So what's a person's chances of possibly having cancer like in the future? Has there been any like studies done for people who have had like benign tumors?
So for people who've had benign breast biopsies, it depends on what they show on the pathology. So there are certain features that put you at higher risk for breast cancer. So for something called lobular carcinoma in situ, those patients tend to have a higher risk of developing a breast cancer. Something called atypical ductal hyperplasia, you got to keep a little bit of a closer eye. So it's important to actually go back and try to get your pathology report, understand, is it completely benign, like a fibroadenoma, where you have no risk of developing a breast
They
cancer?
told me HPV was in there.
I've never heard of an
That's what-
HPV in a biopsy, but
that's what I
I
was
would
told.
I'd actually go back, because you can actually go back and get your pathology report, and then maybe talk to your doctor again about, does this put you at increased risk? There is actually a risk calculator that's online, that actually tells you what your percent chance of developing breast cancer is compared to the average population. And so a number of primary care physicians are very comfortable in using that. And so that's another thing that there are a number of factors you plug into it, and it tells you what your risk is. And so that's another thing that you can think about doing.
Do we have any other questions? We do have a question up here. Thank you. And if we have any questions online, feel free to share those.
I want to have you address when you go to the doctor and you have to request a PSA. They're very reluctant to even do a rectal exam. What the doctors shared with me was because they said that the diagnosis was not reliable, and so therefore they just basically stopped doing them. Can you speak to that?
So there is there's a group called the U.S. Preventative Task Force that actually makes guidelines about when you should be screened and when you should not. And I'm old enough to see these recommendations kind of swing back and forth. So there was a recommendation at one point a number of years ago that suggested not doing any screening at all. However, this is my personal opinion, and there are other cancer groups that agree with this, that people should be screened, and particularly black males, because black males tend to have more biologically aggressive disease. And so if that's the case, then you really need to know. And you need to know, if you do have prostate cancer, is it one that really needs to be treated? Because remember, the slide that I showed said not everything needs to be treated, but at least it allows you to have a dialogue to say, okay, what then is the recommendation? Now, if somebody is 80 years old, 85 years old, 90 years old, their chances of dying of prostate cancer, if they haven't had it by then, probably really low. And sometimes the interventions can be create more bother than benefit. But I would still really have that. If you really feel that you want to have that PSA, they'll order it for you.
They will do the PSA, but basically what the doctor was saying was the results are not reliable.
They are reliable. They'll tell you what they're not reliable to tell you, do you have prostate cancer, in that you can get an elevated PSA from benign enlargement, but sometimes it's the level of the PSA or how quickly it rises. So sometimes they'll do a PSA, and they'll say, okay, I want you to come back in several months. Let's repeat it and see what it's doing, and then if it's rising rapidly or something else is not seeming to add up, we'll do a biopsy. So it's not specific, meaning that it doesn't only diagnose prostate cancer, but it is a reliable test. Does that make sense?
Yes. Now, the rectal exam, it was like I was speaking another language.
Yeah, a lot of times they don't do a rectal exam, and sometimes they'll do a rectal exam primarily if there's a suspicion of prostate cancer. Interestingly, black men tend to have a higher rate of having prostate cancer in the front lobe, where you can't reach it on rectal exam, although the vast majority are in the back. I think at the very least having a PSA Good. And it really goes to advocating for yourself. Because, I think one of the most powerful stories one of our CBBC members tells us, she was 35. She felt something in her breast. She went to the doctor. They said, "You're too young to have breast cancer." And she's a smart woman, right? And she's like, okay. But then she felt it was growing. And they still didn't want to give her imaging. And she insisted. And lo and behold, she had a breast cancer that had spread to the nodes. So you have to be an advocate. If something is different, if something has changed, if you're concerned about it, have your clinician get to the bottom of it. Even if they say this is nothing, we've tested, we know. And if you don't feel like they're taking you seriously, go find another doctor. If you don't feel comfortable and you don't feel that you're listened to, get another opinion. We have to advocate for ourselves.
That's great. Did you have anything else, Pastor?
No, but I just so appreciate the information because a lot of men are being told that the tests are not necessary because it's such a slow reacting cancer. So I really do appreciate the insight that you shared.
Thank you.
And I think that is so important. We talk about prevention, but I think one of the things that I think Dr. Pullen said it on our first day of Summer Health Series. He said we have to advocate for ourselves, and if we don't know, ask someone to support us, help us, and have a better understanding. When we talked about that when we talked about hypertension and diabetes, and the fact that you're going to the doctor and you have high blood pressure because you are an African American male, and immediately instead of looking at non-pharmacological treatment, they go right to let's start you on these medications without suggesting what you should do to prevent from taking medication. So I think that speaks volumes, and I think these stories that we're sharing is so important, especially the story that was shared today by Sister Billingsley, and then also the questions that are being asked in the audience. Do we have any other questions?
Sister Billingsley.
Oh, you have a question?
Oh,
Yes.
let them finish.
I've been very faithful with my mammograms, and I had a biopsy on one, and it wasn't cancer, which is good, but I keep experiencing pain in just one side. And so every time I go back, I keep asking, they keep sending me to specialists, and they keep telling me it's just tissue. And so I want to know, do I push more? And what do I push for them to find out what this pain is?
Yeah, there are different folks that can be breast specialists, for example. So sometimes patients can have what they call mastalgia, meaning that it's pain in the breast. It can be one side versus both. Sometimes they need to do a diagnostic mammogram rather than a screening. So a screening mammogram is when you're totally asymptomatic. A diagnostic mammogram is when you have a specific complaint and they take more images or views. Sometimes they will do an additional ultrasound to see. So you may want to check someone else to see what their thought is. Sometimes you can do all the imaging. I wouldn't necessarily recommend an MRI, because a lot of times that leads you down a rabbit hole where they find something that's never going to be of a problem. And so then you get in this biopsy kind of spinning, looping. Now, MRIs, once you've been diagnosed, they're a different story. But those are just some of my thoughts.
And what I wanted to also bring up, with what you kind of shared, again, the support system, and I thank God for my husband. I failed to acknowledge that man, he was tremendous with me, helping me bathe, all the things that needed to be done, lotioning me up. But he also went with me to my doctor's appointment, because a lot of times that you can get kind of just too much knowledge, and you just don't know which way to turn. But my question is, with the after my radiation treatment that I had, my doctors are, suggesting hormone, I guess it's called hormone treatment. Where can I find more knowledge about that? Because I'm wondering if it's really necessary, but again, can you kind of elaborate on that a little
So
bit?
sometimes women who have what they call hormone-positive cancers need hormone blockers to kind of dry up the remaining estrogen that's floating around in the body that can act as food for the cancer cells. And so you can go on to different sites like American Cancer Society, Mayo Clinic, National Cancer Institute, and just kind of type in hormone blockers or the name of the drug that they're recommending and learn more about it.
Okay.
Yeah.
Could you repeat those again?
So American Cancer Society website, Mayo Clinic's website, National Cancer Institute, any of the major cancer centers like, in addition to us, Memorial Sloan Kettering, MD Anderson. Again, kind of stay away from some of the things that are not necessarily what we call peer-reviewed or scientific on the internet, because a lot of times it can lead you astray.
Okay. Are there any other questions?
I'm just really thankful for our speaker on this evening, and and maybe she'll cover this later, but I would like to know how to, what more about enrolling or joining with the coalition.
Yep. So in the back, we have palm cards that tell about the organization. If you send us an email, or Dr. Allen can give you my email and get you on our distribution list, because we definitely have to have you. But also cbbcaz.org is our website, and that also gives you an ability to get into us. So it's cbbcaz.org. And then we have a CBAC website that we're constructing. But all of the information is on the cards in the back. Dr. Allen and Dr. Pullins have been great members, and so they can also give you information as well.
Thank you so much. And that is cbbcaz.org. On that homepage, you'll see the homepage, you'll see information about CBBC and the other organizations that will be established. You also see their story, which is phenomenal. And I love the fact that you'll see stories. I think we have one of our other members here, Sister Ann Walker, whose picture and story is also on there. Also, for opportunities of donation, there is a donation link. We encourage members to donate, those who are online, to donate to support the cause. We also have opportunities, and I know there was a question that was going to be asked about partnership. There's a young lady that I spoke to who does hair, strands for hair, I believe, and she's interested in partnering with CBBC and CBAC as a whole to support them and find out ways in which they can work collaboratively together. So I know she'll be reaching out. And I want to see if there are any other questions before we...
Dr. Allen,
Yes.
there was an online question.
Okay.
That question was, how effective is routine mammogram versus another type of higher mammogram?
So the question is, how effective is a routine mammogram versus a higher level? So I think I know what you mean. So most of the mammograms now are what we call 3D or three-dimensional mammograms, and those are most mammography centers use that. All mammography centers have to be accredited by the American College of Radiology. So basically all mammography centers have to pass a kind of a standards test. If somebody has a specific problem, like I feel a breast lump, I have a discharge in my breast, something's going on, they may, they likely should be screened with what's called a diagnostic mammogram. Same type of machine, it's the same machine, but they actually do different angles, and sometimes they need to do a little, what they call spot compression, or a little different way. There are other mammograms, such as contrast enhanced mammogram, which is where we give dye with the mammogram. It makes the mammogram almost as sensitive as an MRI, which is a different type of an X-ray. Mammograms pick up about 90% of things, but there are some false negatives. There are some certain types of breast cancer, such as what we call lobular, invasive lobular, where it starts in the milk ducts. I showed you that cartoon of the breast versus the duct itself, and sometimes those don't show up on mammogram. So, and sometimes we have to use additional imaging, such as an ultrasound. Ultrasounds are not a good screening tool. MRIs are not a good screening tool. Mammogram is really the gold standard.
Did that answer your question? I believe it did.
Hopefully it did.
Hopefully it did, yeah.
I believe it did. Thank you very much.
Thank you. So again, we thank you for this session, and I wanted to see if we can go to the last slide, our flyer, if you will, for our Summer Health Series, if we're wrapping this evening up. And if we can, great, but I want to just kind of plug in, it's actually the Summer Health Series slide. I want to plug in our upcoming Summer Health Series events before I call our pastor up. I want to welcome again all of the individuals that are here. We want to make sure that we encourage you to continue to come out. What we'll be talking about next week, we actually had an opportunity to combine Alzheimer's disease-related dementia, grief, and loss together. So next week, we have a speaker that will be coming from Banner Alzheimer's Institute, Dr. Danielle Goldfarb, who will be talking a little bit about dementia, but she is going to transition into a term that many of you, I don't know if you're familiar with, I'll be interviewing her on ambiguous loss. And it's typically losing an individual who's physically present but psychologically not there, and also the reverse, losing a person who you psychologically have actually seen but physically is not present. So it's a little complex, but I'm hoping each and every one of you all are here present so that when we speak about that, it's going to be a combination of what we've dealt with, not only with dementia, but also during the pandemic of losing so many individuals. So we do have another lineup, second half. We're going into our July month. So we'll be doing emergency preparedness, where we'll have our very own brother Dunn, who will be speaking about emergency preparedness, financial planning and investments, which I think is going to be huge because we have a phenomenal speaker who's going to be enlightening us on how do we get through this financial crunch that we're going through. Gas prices are up, mortgage, rent, all of the things that we're challenged to do. How do we manage our funds? And then last but not least, as I pointed out during this presentation, the genealogy. That is pretty much is a full circle. We talked about the beginning of all of our health concerns, and then we're going to talk about where do they come from. So it is an honor and a privilege to have many of you all here. For those of you who all are in house, I just want to remind you, if you have a ticket, we will be raffling off a gift. But before we call our pastor up and close out, I would like to have, I believe we have a special gift for our, and I want to do this online so people could see, a special gift for our speakers. Okay, so we're going to, our speakers. So Sister Billingsley, again, we thank you for presenting. I know it's a little something you say, oh, I'm uncomfortable. So CBBC had an opportunity to actually go shopping for you and get you some wonderful gifts. Thank you. This is awesome. So thank you again, CBBC, for allowing, having this evening spent with us. And again, Sister Billingsley, for allowing us to utilize your time and your story to share. So thank you. So without further ado, we will be calling our pastor up, and we'll stay seated while he gives our closing remarks. So thank you.
Let's give everyone a hand. I'll stand here so that I can see everyone. I was just thinking how wonderful it is for us to live life from the perspective of having understanding rather than being dominated by fear. Knowledge is power, and having the knowledge of how to better maintain your health, that is so important. I want to thank Dr. Halyard for being here, Sister Billingsley, and of course Dr. Allen for just a tremendous presentation. My grandfather was in his 90s and was diagnosed with prostate cancer. The treatment, I think, probably ended his life rather than the cancer, because the radiation, he wasn't able to bear that. But we were ignorant. We didn't know. But we know better. We have options. We have the ability to be able to talk to professionals that are able to give us good advice and advocate for your health. I remember that. My wife is a proponent of that. Don't let someone else control your health journey. Speak up for yourself. Ask questions. Educate yourself before you go to the doctor. All those things are very, very important. But again, I want to just thank you for a tremendous service that you're paying to our church and all those who are listening online. This is important. And I want to remind the men to remember our 90-day health challenge. That's going to make us better, more viable, and we're going to, hopefully in 90 days, you're going to see a marked difference in our health and as well as in our appearance. So all of us are trying very hard to live healthier lives, drink water, but also interacting with one another as well. So I want to put that plug in for the brethren. And definitely next week we want to be here to hear about Alzheimer's and dementia. I think that'll be a very interesting subject, something that we all are having to contend with. Thank you, Sister Billingsley, for being so transparent and sharing your journey with us. I really do appreciate that. I also would just ask that you pray for people who are not health literate. That they'll watch the programs, and we need you to be an advocate to remind people in your families, your people you have influence with, and tell them that there's a wealth of information that can be gained by watching the Summer Health Series. With that, we're standing. Also want to thank all of you online for tuning in, and I ask that you share the information with your friends so that they can tune in as well. Let us bow. Lord Jesus, we are so grateful for what our ears have been able to hear, our minds able to perceive. We ask that you will enable us to take the knowledge that we have gained and use it not only for our own benefit, but also for the benefit of others. Lord, we pray for these medical professionals who have devoted their lives to improving the human condition. We ask that you would bless them, bless their families. Bless them, O God, to realize how much we appreciate the sacrifices that they have made. And we ask that you would enable them to continue to share this knowledge in all over the valley and all over the world, that people everywhere will know that the word cancer does not mean death. You can yet live if you receive the proper treatment and are willing to go through the appropriate process. Now, Lord, we thank you for how you've delivered Sister Christine, and we have others in our congregation that you've delivered as well. And we're so grateful for the medical advances. We're grateful for the prayers that have gone up. We believe that all of these things work together to help us to live healthy and to live long and to live well. We ask this now in the precious name of Jesus. And everyone said, amen. Greet your neighbor and let them know how much you appreciate them coming out tonight. Also, we'll be doing the raffle tonight, so I'm going to let Dr. Allen do that. Have a wonderful evening, Dr. Allen.